Hello, everyone. This is Bhavin from EndoArt here, and welcome to a presentation which is geared towards discussing the requirements for your clinical case portfolio. This is aligned to the checklist that you have been provided, and just want to discuss the points in the checklist so they're all clear for you, and hopefully this gives a point of explanation for any queries you may have. So let's get started. So we'll go through the following points, which are the format and submission, the clinical content, the radiographs and clinical images, diagnoses, treatment options, treatment plan, treatment execution, and case discussion and reflection. So first points are related to the format and submission of the portfolio. Obviously, you'll be sending us one case first, which we will review in detail and give you feedback. And hopefully your second, possibly third submission will be of the required standard. Any feedback we give you, it's really important that you apply these to all the subsequent cases once we give you the go-ahead to do so. So obviously this is after you've had your first case approved. The first requirement is in terms of the format is that all 10 cases are compiled into a single PDF document with the title page at the front. So we want all of the cases in one document, and it must be in PDF format with the title page. All pages should be sequentially numbered, and each case is numbered 1 to 10, and where you are starting a new case, make sure that's on a new page. It's fine to use abbreviations, and that's absolutely fine. But just to make sure that we understand what these are, it would be very useful if you provide a bibliography of all abbreviations that you have used in your submission, and that can be put at the front of your cases after your title page. Obviously, it's important that we know who you are, so make sure you put your name on there and that it's your clinical case submission. You should send these to the info@endoart.co.uk address, and any subheadings used in the template for the clinical case submission have been followed. So we've got our template case, so you must include those. Again, you can use additional subheadings if you require. The template is not a hard and fast template that you have to use, but what we're trying to do is ensure that you include all of the required subheadings that are included in there, plus any additional ones that you think are necessary. The next point is to avoid unnecessary capital letters. So using certain words, for example, sodium hypochlorite would not be with capitals, for example, or just including capital letters randomly in the text. We really would prefer if you can try and avoid. So using your, your grammar and punctuation function on Word will be useful for this purpose, but you might need to review that document just to make sure that isn't happening too frequently. With regards to the clinical content, we'll just go through this, and just as I made the point earlier, any points that we raised and that you've addressed in your initial case submission, make sure you follow these through to everything else that you then send on to us. We want to see that you've carried out a thorough clinical examination, and what's very important here is that you have demonstrated that you've carried out a full periodontal restorative, caries and tooth wear examination, and obviously anything that we can see in your clinical images and your radiographs and most importantly, not necessarily related to the tooth that you're treating, must be identified, diagnosed, and put into the treatment plan where necessary. Obviously, going on later, and we'll talk about that more, if you're not the treating clinician or the general dentist of the patient and are just carrying out endodontic treatment, we want to see a very clear explanation for who is going to be doing the treatment, how this has been communicated, and obviously in your follow-up, it has to be clear that that has been addressed ideally, or there has to be a very good explanation for why it hasn't been done if we see untreated disease in subsequent radiographs or images. It's always great to have clinical photographs, so include these wherever possible. It makes the case interesting for us to discuss, and also can clarify things such as restorability and other aspects of the care. So wherever these are possible, they're not essential and certainly not required for every single case in entirety. But as I say, the more you include, the more useful for us. And this is a very key point, that we should always strive to carry out a full and comprehensive restorability assessment. That means full coronal disassembly of all restorations, and then, if necessary, pre-endodontic build-up. Talk about that in a moment. And we have to see that rubber dam isolation has been achievable in all cases. And that's where, if it's contentious based on radiographic images, the clinical photos will be really helpful to explain this. I'll go on to situations where maybe coronal disassembly hasn't been performed, because it's obviously there may be exceptional circumstances, but certainly it should not be a theme through your cases. Key points here. The treatment plan includes all necessary dental treatment, including the post-endodontic restoration, and actually the follow-up is an integral part of the treatment plan. Again, just highlighting that any other disease which has been identified in the patient, be it periodontal, tooth wear, has to follow through from diagnosis to treatment plan to follow-up. So we need to have that throughout. A follow-up plan is described, and you should just be universal in applying the ESE guidance with regards to the follow-ups, stating that you're following this, and we should see clinical and radiographic follow-up wherever possible. If you've submitted 10 cases without follow-up, that's going to be a little bit disappointing to see. So wherever possible, the evidence of a successful treatment is the follow-up. So it's clearly desirable for us to see this. And also, when we talk about follow-up, let's also remember to talk about the other aspects of the treatment that were identified and treatment planned initially. Again, there may be scenarios, if you're not the clinician who's responsible for the overall care of the patient, then there may be scenarios where that is carried out by your referring colleague, but we want to see a clear and appropriate way of communication, which you can discuss in your case between you and your referrer, because that's an integral part of the patient care experience and pathway. But furthermore, if the treatment hasn't been carried out, you'll need to justify it. And with all these things, I think if they're happening as a one-off in a single case, that's fine. But if we see these themes with regards to particularly coronal disassembly, other untreated disease, or follow-up, or other outstanding treatment crop up in multiple cases, it's very difficult for us to then justify your progression from this point, if that's a common theme throughout. So radiographic images and clinical images. So these should obviously be conforming to the necessary standards and requirements. So we've got the original radiographs, which are high quality. They are not photos that are taken with a phone of your radiograph and in particular on a screen. These should be the original images. As you probably know, the requirements for a periapical radiograph is that we include the entire root canal anatomy and surrounding tissues, ideally 2 to 3 millimeters surrounding the tooth. And we need to make sure that, as I said, they're not photos. Now, each radiograph should be described with a report, and this should state the diagnostic quality, the teeth that are present, the bone levels, the presence of calculus, the presence of restorations and their integrity, any evidence of caries, the periapical status of the teeth, comments on the root canal anatomy, that might be the length, the curvature, the number of roots, the level of calcification, and possibly then the neighboring anatomical structures such as the ID canal, the mental foramen, or the maxillary sinus. That should be in a legend. I might repeat this later, but that should be in a legend which is under that specific radiograph, and this report should not be within the main body of text. It should be attached below the radiographic image. The same goes for your photographs. Let's make sure that you have a legend which describes what is shown in the clinical photo. And these images, as I've explained, they should be embedded within the relevant text. So you have these as the text within the text at the relevant point. So if you're talking about your master cone radiograph in your description of your clinical treatment, the cone fit radiograph should be placed in within that text. Don't put all the images at the end of the case report for us to then go and have to look for them. They should be numbered and titled correctly. So at the start of your legend, you would have figure 1, preoperative radiograph, and then go on to the points we made before about the diagnostic quality, the teeth present, and then describing the full image and not just the tooth that you are working on. And the diagnostic radiographs, again, we want to make sure that you have the quality of the radiograph is good. If the apices of the tooth are coned off on that radiograph, then it's a non-diagnostic image for the purpose of what it is. You may feel that it may be better not to include that radiograph, but obviously where you have been able to include it, please comment on the length control, because this will then allow us to discuss the case should there be an issue with length control further on. So it's not a requirement to have a diagnostic radiograph, as long as you have an excellent preoperative and postoperative radiograph and have used a apex locator reliably during the treatment. However, if you have a scenario where the length control isn't ideal and you don't have an intraoperative radiograph, again, that is a point for discussion later on. And if you have a good quality radiograph and there's an issue with the working length or the cone fit, then that's fine. But we want to see how you then overcame it. So if you were long, talk about how you adjusted the cone or the gauge, or both. If you were short, what happened in that particular case, how did you correct, and then how did you verify the new length as and when you got there. So I hope that's clear. The diagnoses. It's best just to stick to one source for diagnoses, and probably we can use the British Endodontic Society, a guide to good endodontic practice, and there's a table in there which describes the diagnosis and the terminology you should use. Don't mix and match diagnoses. So, don't use, because the terminology all differs slightly. So we want to see consistency throughout your cases using one particular source. Make sure that your diagnoses tally with what you have made it with your clinical findings, your sensibility testing, your radiographic findings, the presence of, swelling. All of this should be incorporated into there, and you should be cross-referencing your clinical and radiographic findings with your diagnoses to make sure that you're happy with that. So that's super important. So this is really, really what I've just said here in terms of the first 2 points. And obviously, as we have discussed at numerous points along the way, the pulpal and the periapical diagnoses should be clearly stated. Yeah, we can have a healthy pulp or a normal pulp, and separate periapical diagnoses. You could have healthy periapical tissues and obviously a pulpitis as a pulpal diagnosis. So either are possible. So, but we still need to see that diagnosis made clearly. All right, and obviously just consider this for all your other dental findings, whether they be periodontal, tooth wear, caries, etc. A common point of error in the cases is that the periodontal diagnosis is either not reported accurately or appropriately, and this might be because you've stated a certain BPE, and then there are copious deposits of calculus on the radiographs that you've provided, which is we've got to kind of combine to make our diagnoses. So make sure that's identified and then diagnosed correctly, and the correct diagnosis has been put down, and this is then incorporated into your treatment plan. We see the treatment has been done, and that obviously in your follow-up, if that same radiograph has calculus there, but the treatment has been done, again, we've just got to be able to correlate all of these things to make sure that they will follow through and tally up. Same goes for caries, defective restorations, cracks, and tooth wear. Primary disease stabilization is just absolute, imperative gold standard practice. So any of this not identified should will be an issue. If you have cracks in the teeth, you need to basically identify these initially. Of course, cracks might not be identified in the initial clinical exam, but if these then transpire to be found during the treatment, we want to see some discussion of that. And this is a key point. Things will change, for example, when you're carrying out your treatment, your pulpal diagnosis might change. When you access the tooth, you may become aware of cracks that you didn't know about, but please just discuss these, and then in your reflection later on, again, these can be discussed. Tooth wear management might not be something that you're necessarily going to do, but there has to be a conversation with the patient. So it might be that you've identified tooth wear, you've identified the etiology of the tooth wear, you've had a discussion with the patient regarding, addressing erosive tooth surface loss, attritional tooth surface loss, and where there's been, a loss of vertical height, you might consider either managing that or referring, and at least these conversations have been had. So, just by clarifying that with us, it means that we're not going to ask questions about that. But an absolute must is all primary disease must be stable and addressed, and outstanding treatment is diagnosed for sure. And yeah, for that reason, we've included, make sure you diagnose and list everything in your diagnosis. And again, just reiterating, this follows through to your treatment planning, discussions, and treatment. And the diagnoses should be numbered in a logical and consistent order across all cases. So have an order for, you know, your soft tissue diagnoses and then, you know, your dental diagnoses, so that you keep that consistent throughout your case presentations. So to treatment options, the point is that there are options, and you know, let's make sure that we at least have stated that we've discussed all of these with the patient, and we want the treatment options to be listed and numbered for each diagnosis. And let's try and again keep consistency with the diagnoses and then the treatment options. So we've got these kind of listed in a logical order, and remember, for the teeth that you might have presented to us, we're going to have endodontic options will always be extraction and no treatment as well. And you can discuss that you've had that conversation and the pros and cons have been addressed. And then what we want to see is your basically assessment, your case assessment. So a little bit about the case that you're about to treat. So it might be that you have talked about possibly the depth of the caries being an issue in terms of restorability, and that needs to be assessed. We want to talk about the actual root canal anatomy. There might be calcification, and that you've discussed about issues with negotiating, and preparing the canals. In a retreatment, it might be, you know, difficulty addressing working length because of a ledge in the canal. So again, just a little brief discussion that you have had a chat with the patient about the challenges of that specific case. So this can go into your treatment discussion area. And you know that you after consideration, the patient has decided to proceed, and an important part of this in guiding the patient will be a prognosis. Now, prognosis, you might talk about, you might want to use an index like the dental practicality index. You might want to talk about the restorative prognosis, the periodontal prognosis and the endodontic prognosis, the overall prognosis, and then just a brief discussion. But again, you know, you're going to talk about these things, and that we want to see something of that effect in your discussion. And then we go to the treatment plan. We must address all the diagnoses following a logical sequence and identify responsibility for all treatments. So what that means is, if you're not the one doing it, we want to make sure that you've got a plan in place for that patient's dental care. So here everything is fairly self-explanatory. You've got a logical sequence to the treatment plan. It's numbered. The treatment plan correlates with all diagnoses and treatment options. All diagnoses are addressed within the plan, and we're just highlighting this point again, not just the tooth undergoing endodontic treatment, and again, not forgetting the perio or tooth wear. If other treatment is required but not carried out by the learner, the responsible clinician is identified and communication is documented. So that's really important. Sorry if a lot of this is, I'm reiterating the same points, which as I read it, I can see, but just for completeness sake, we'll just go through it. So let's go into the actual treatment execution. So this is how you document what you actually did. So we don't want to see copy and paste repetition across cases. Now, of course, if you're carrying out endodontic treatment, then largely your processes and techniques are going to be similar. But what we have seen many times is that perhaps the exact same instrument has been used to finish every single case. Sometimes there's been a situation where it's a retreatment, and in the treatment notes it says that we accessed necrotic pulp because it was copy and pasted from a previous case. So, for example, those would be the main things where you access the tooth and you find that there's the canal contents are specific to that case. got to make sure that these are all, it's not looking like it's copied from a previous case. And we've seen that with diagnoses as well. So very important. Again, just highlighting spelling and grammar checking and unnecessary capitalization. If you're using a product brand name like Dentsply or Wave One Gold, these will obviously start with a capital letter, and then you can use the trademark, or I forgot what the other symbol is, but the one I'm talking about, next to it. And all materials listed as product, and then the manufacturer, the town, and the country. So it might be Wave One Gold, Dentsply Sirona, Balague, Switzerland, for example, is a example of that. If you do wish, you can have another, like you can have a bibliography for your abbreviations. You can have all your materials listed in a similar kind of list, just to clarify all of the product details in terms of the manufacturer, the town, and the country. Then it's acceptable for you to just say Wave One Gold, and in your list you've got Wave One Gold and these specifics here. But please remember just to use the trademark sign as well. Hope that's clear. Please do record percentages, and also actually we don't have it here, but please make sure that you clarify that you're using solution, so 3% sodium hypochlorite solution, and then you could have your manufacturer name, which could be Parkan, Septodont, wherever it's made, town and country. So that would be a 3% solution. For EDTA, you could be using a gel or a solution. So that's why we prefer if you use, and how you deliver that irrigant. Are you using a 27 gauge side venting irrigating syringe? Are you using Irriflex tip, something like that? So just make sure you clarify that. And again, this is just going back to the point I was making earlier. When you access the tooth, we will always find cases where the pulp status might be different to our initial diagnosis. It might just be purely because it's been a few weeks since we saw the patient, or the tooth has partial necrosis, and you found some pulpal tissue or pus or purulence. This will also be relevant to why you did the case in 1 or 2 visits. So it's important we see that. And we also want to see a discussion of why you carried out the case in 1 or 2 visits, the justification for that. So again, let's make sure that that isn't, for each case, it is discussed specifically for each case, rather than it being just a generic first case, calcium hydroxide. Let's see, the canals could not be dried, or it took me very long time to negotiate the canals to full length, so it was felt that sufficient cleaning had not been carried out, therefore opted for a 2-visit treatment with non-setting calcium hydroxide, etc. So we talked about this again, just this percentage thing. It's coming up as twice because it's consistently been left out previously. So, and yeah, I've just touched on this. Why did you choose a single or multiple visit treatment? So let's have some justification. Might be that even you just took ages to build up the tooth, establish the restorability. That's fine, as long as there's just some discussion. What inter-appointment medicaments you used, and obviously, we're really looking at non-setting calcium hydroxide here as the gold standard for your inter-appointment medicament. It would be difficult to justify the use of Ledamix in a necrotic case. So, that's something we would definitely call you up on, and how you used it, and also how you temporize the tooth. Let's make sure that you've followed a good protocol with a good antibacterial seal, and structural integrity of your temporization between appointments. And again, You can use, so with regards to your treatment, this is your, it might be appointment one, appointment two, what you did in each appointment. It's perfectly fine to use bullet points as well. Don't forget things like local anesthetic, how it's been administered, what solutions have been used, etc. Sometimes we find the local anesthetic has been protocols have been copy and pasted as well. So you have a lower 7, which has been treated with a buccal and palatal infiltration. So clearly that's not going to be correct in that case. If you've got irreversible pulpitis in a lower molar, your strategy for local anesthesia is going to be different to if you've got a necrotic upper central. So, both in terms of how the local is delivered and the solutions that might be used. We want to see if you had problems with anesthesia, how you managed and overcame these. So it may be in those cases that you could only do so much, and that might be an indication for the use of Ledamix in those scenarios. But make sure it's all logic. It all relates back to what you're seeing and what you've diagnosed and what you found during your treatment. And then finally, we just go into the case discussion and reflection. We want to see genuine case specific learning. Again, this has been a copy and paste issue, perhaps, where the discussions are very similar in each case. Just something you learned specifically in that case. Try and look at one point, and then relate that to maybe some evidence that you can then use as a little paragraph of discussion about that point. It could be a separate point if you want to use some evidence based, and but definitely it must contain some aspect of case specific reflection, and it must contain some case specific evidence based discussion and the referencing I'll go on to. So this is very much what we're talking about. Discussions are case specific. What went well, what learning points were identified, where treatment did not go ideally, that's absolutely fine. Again, if it's not a recurring theme. So again, just to highlight a common point we've encountered is I should have removed the entire restoration and caries, but on this case I didn't. My learning point is that I should have removed the next time I will do that. And then the next case that we read has the same issue. So, the reflection has to instigate change for it to be meaningful and tangible. So let's try and see that. And so, and this really is just avoiding repetition. So learning points are not repeated. If resolved in one case, it should not appear. So again, I'm talking ahead of what I'm reading. So sorry about that. And yes, I've talked about this, a specific clinical aspect of the case is discussed during evidence. References is another thing. So they should be from peer-reviewed sources. Yeah. So if you look at our reading list and then the references within those articles and papers, you have more than enough good quality references to use for your cases. So, going on to Google or asking, ChatGPT or Claude might work, but it might lead you to a very scientifically poor paper that we would not want you to be using as a reference. So it is important that you use good evidence from good research. So let's try and stick with that. Do not use any website links or case reports. Perhaps if you've got a case report in a high quality journal and you're doing something slightly unique, that might be valid, but try and avoid if possible. References should be varied across all cases, so let's not have repetition of the same references. And these references should be numbered for each case in alphabetical order. So that means case 1 is 1, 2, 3. And then case 2 will be 1, 2, 3, 4, not case 1, 1, 2, 3, and then case 2 is 4, 5, 6. So we want to see, and you only need 3, maybe 4 references per case is sufficient. You can include more, of course, but that is more than enough for you to the submission. And then last but not least, we do need you to make some declarations that it is entirely your own work, and that, you know, obviously we are imparting that trust on you, and all cases comply with the EndoArt submission requirements. And finally, that you have read and understood the entire checklist and made sure that your cases conform to all of the requirements on the portfolio checklist. So you're happy that you've done everything required for this, and that it complies with that. I hope that is useful. And of course, this is all with reference to the EndoArt checklist, which will be in your member login area for you to, and it actually has tick boxes. So if you want to, you can actually do that for your cases. And make sure that you're sending us. And this will, and sorry for the repetition here. This is really just to make your life easier, primarily, so that we're not sending you a really long list of things, and especially, you know, things like simple things like page numbering and formatting. You know, we don't want you to have to go through trawling through all of this, and the frustration of that, and also for us making these points proactively, and prior to prospectively, you know, it helps us to help you. So I hope that's useful. So I think that's it. And if you also just have a quick look at the document, the checklist now, it will be basically hopefully provide clarity on the points in there, and will be helpful for you going forward. Good luck to you all, and we look forward to seeing your submissions. Take care. Bye bye.